of non-surgical endodontics, root canal treatment requires the use of files and instruments to remove necrotic and infected tissues. The steps in this process are to use a hand file to obtain patency in all the root canals of a tooth, to measure the working length of the teeth, and then to use rotary instrument to shape the root canals in preparation for sealing and obturation. If these steps are performed correctly, endodontic treatment can retain a tooth that would otherwise require extraction. Cleaning and shaping of the root canals. Cleaning and shaping are separate concepts but are always performed together. The goal of cleaning of the root canal is the removal of necrotic bulb and infected tissues. The goal of shaping the canal is to maintain the apical foramina as small as possible in its original anatomical position. A good endodontic treatment outcomes is dependent on the removal of necrotic bulb and infected tissues to a low level that cannot cause a flare-up, which will require retreatment. If the root canals are cleaned and shared adequately, the flare-up rate can be less than 2% of cases. Although there are some reports of a 10% flare-up rate, teeth with a less infected root canal or which have been infected with microorganisms for less time generally lack a pre-radicular pathosis, and the success of endodontic treatment in these teeth is generally higher. Teeth which have a periodicular pathosis on radiographs are more infected, and these teeth are more difficult to treat and have a higher risk of flare-ups and requiring retreatment. Most significant factors affecting the instrumentation of teeth are tooth anatomy and morphology and the type of instruments and organs used for treatment. Instruments must contact the root canal tissues to debride the canal. However, it has been shown that most of the root canal surfaces are not touched by hand files or instruments, even with best efforts of the dentists. The reasons why most of the surfaces are not touched are because of the ribbon, conical or irregular shape of the canal, presence of accessory canals, lateral canals, canal curvature, fins, cul-de-sacs, and isthmus, which make total debridement virtually impossible. Because of these obstacles in accomplishing the complete debridement and total elimination of infection inside the root canal, the goal of cleaning and shaping is to maximize the removal of necrotic and infected tissues, thereby reducing the risk of flare-up and failure of the treatment. Prior to beginning root canal treatment, the case should take into account all these factors for its degree of difficulty. If it's beyond the experience and skills of the dentist, it should be referred to a specialist for supervision or treatment. Root canal instrumentation. Root canal instrumentation after a straight line access. Cavity has been cut to allow direct access of the instruments into the root canals, and the orifices of the root canals have been identified. The next step is to instrument the root canals. The instrumentation process can be simplified by dividing the procedure in a series of steps. The majority of teeth are approximately 90 to 25 millimeter in length. Most roots are 9 to 15 millimeter, and most crowns are 10 millimeter in length. An easy concept is to divide the root canal into three regions: coronal, middle, and apical. Each of these regions is likely to be between 3 and 5 millimeter in length. Dividing the root canal into three regions is a helpful strategy for instrumenting complicated calcified root canals with a challenging morphology. Most guidelines for endodontic association recommend that the root canal is irrigated with undiluted sodium hypochlorite and concentration of 5.25, 6.5, and 8%. However, many dentists dilute the concentration of sodium hypochlorite by half to 3%, or even more to 1.5%. The main reasons for diluting the sodium hypochlorite are to limit the injury caused to patients if the sodium hypochlorite spills or leaks. After checking the preoperative radiographs of the tooth to be treated, the 0.02 tapered 10 and 15 stainless steel hand files are measured and curved by the dentist to match the length and curvature of the root canal. These hand files are then placed inside the tooth to explore the coronal and middle thirds of the root canals. When the hand files are placed inside the canal and have been rotated to remove the tissue and make some space, a syringe is used to deliver a small volume of sodium hypochlorite into the space. Sodium hypochlorite can help lubricate the file and reduce the friction of the movement of the hand files into the canals. Once hand files have been progressed through the coronal and middle regions of the root canals, the canal may be enlarged using hand files prior to instrumentation with rotary night-high root canal shaping instruments. After the coronal and middle thirds of the root canal are negotiated, small hand files are used to scout the remaining apical third of the canal. After this stage in the instrumentation of the root canal, it must be measured to avoid over instrumentation.